So let's go ahead and start the nerve plexus. The cervical plexus, like we said, this plexus starts from spinal nerves coming together and forming these plexuses. So for the cervical area, you will have the cervical plexus, which is made up of cervical spinal nerves C1 to C5. C1 to C5. So this comes out of the spinal nerve at the neck area. When they combine, they will lead to individual nerves. And the most prominent of these nerves in the individual nerve outlay is the phrenic nerve. The phrenic nerve is your nerve to the diaphragm. So every time you breathe and the diaphragm is stimulated by the phrenic nerve, the diaphragm contracts and it goes downwards, therefore pulling with it the lung, making the lung expand. So the phrenic nerve is a vital nerve. Huh? If it is not working, then the diaphragm will not be able to contract and you won't be able to breathe. It's interesting that the phrenic nerve is in the neck area. So by some morbidity situation, if the neck area is tightened, that phrenic nerve may be also impinged, right? Huh? So C1 to C5, there's a lot of nerves there. There's a scapular nerve, there's nerves that lead to the muscles of the neck, but the most important there is your phrenic nerve. Now, if this plexuses also form in the area lower than the cervical plexus, they will form the brachial plexus. And the brachial plexus lead from C5 to T1, where T1 means thoracic 1. The nerves coming out of this will supply the upper limb and some of the shoulders and neck. Out of this comes the median nerve. Huh? Median nerve also uh, deficit. If a median nerve is in deficit, it will produce the CTS. That's another abbreviation you may want to write. Carpal tunnel syndrome. It also will produce the ape hand sign, which I will discuss later on. The lumbar plexus supplies the lower back. That's from L1 to L4 and will end up producing important nerves like your femoral nerve, genitofemoral nerve, which will lead down to your medial thigh. The sacral plexus produces L4 to L5, S1 to S4, which will lead to your, together with the coccygeal plexus, will lead to your sciatic nerve. Let's see, here's an outlay of it. See, you'll have your scapular nerve, your auricular nerve, occipital nerve. That's what I was thinking of. Occipital nerve. You'll also have your cervical nerves. This is a C1 to C5 outlay, huh? The cervical plexus. The phrenic nerve, which is right here, is a combination of C5, C4, and C3. See? That produces your phrenic nerve. Your supraclavicular nerve is a combination of your C4 and a little bit of C3. See? They all combine to form new nerves. And again, the most important of this would be your phrenic nerve. Hypoglossal nerve right up there is your 12th cranial nerve, which leads the movement of your tongue, huh? Tongue muscles. Here's a picture of your cervical plexus from a human remains. Okay, way up here. This is the phrenic nerve. Here's another picture of the phrenic nerve, which leads to stimulating the diaphragm right here. Let's go to the next plexus. This is the brachial plexus. Okay, from spinal nerves, they will come together and form important nerves here. Huh? This is the musculocutaneous nerve, the axillary nerve, radial nerve, median nerve, and ulnar nerve. Huh? Especially OTA, you will use a lot of these nerves because you will be taking care a lot of cases taking care of upper extremity conditions. It's very important that you know this. For example, the biceps muscle. Okay, the biceps muscle is stimulated by the musculocutaneous nerve. The deltoids is stimulated by the axillary nerve. So, if the if you have a patient who's using crutches and they were not well positioned, maybe too high, this will impinge the axillary nerve, and the axillary nerve supplies a deltoid. So, your deltoids will not be able to abduct the hand. So you will have weak or no abduction of the hand. We call that crutch paralysis. Axillary nerve, deltoids. Make a mnemonic on that. Like, for example, BMW, you know, the nice car BMW, BM, we usually call them. Well, you can remember that for biceps musculocutaneous. See how I do it? I make mnemonics, I make animations. That's how you want to remember, and easy to remember in anatomy, huh? Make mnemonics, make it your own, make it your personal style or personal method. This will make the retention be stronger. So BM, musculocutaneous biceps, TR, okay, as in triceps, right? Well, triceps is powered by the radial nerve. See the second letter in triceps. Radial nerve stimulating the triceps. So, what's a triceps for? The triceps helps you extend your elbow. Okay, if you're pulling something from the top and you're pulling it down, you're doing a triceps elbow extension. When that, when your radial nerve is not, uh, it's in deficit, therefore you won't have a strong contraction of your triceps. Right? You will have a weak extension of the elbow. In fact, the radial nerve also supplies muscles that make you flex your wrist. So if your wrist is bent, try to lift your arm and let your wrist hang down. In order to lift that, you will make your muscles of the posterior forearm contract. In fact, if you lift that wrist, you can feel the tension of the muscle at the back of your forearm. You try that. Okay, lift the wrist, tension there. See, there's a tense muscles at the back of your forearm. Those muscles are powered by the radial nerve. So, and all the way to the fingers, the digits, extensor digitorum muscles are powered by the radial nerve as well. So if the radial nerve is deficit or dysfunctional, therefore it will not make those muscles contract. You will not be able to lift the wrist and it will fall back down. We call that your wrist drop sign. Radial nerve paralysis is seen as wrist drop sign. You also cannot straighten up your fingers if you have radial nerve paralysis because that's also powered by the radial nerve. Okay, so unable to extend the elbow, unable to extend the wrist and the fingers, radial nerve paralysis. Radial nerve paralysis is also seen on the skin, huh? Numbness of the area just above the elbow, going towards the shoulder, huh? Just above the elbow, I would say proximal to the elbow, the distal third of the upper arm, just proximal to the elbow. Numbness there can also be due to radial nerve paralysis. Okay, huh? Then you have your next nerve, that would be your ulnar nerve. The ulnar nerve, if you have your hand in the anatomical position, the ring finger and the pinky, that's your digit 4 and 5, is actually supplied by your ulnar nerve. Ulnar nerve is based on the name of the bone close to that area, the medial side of your forearm, which is the ulna. So the nerve in that area, we call it the ulnar nerve. The ulnar nerve makes you flex the fourth and the fifth finger, huh? Makes you flex. Now, when you clench your fist, you're supposed to flex all fingers. But because your ulnar nerve, if it's in deficit, is not able to stimulate the muscles that pull the fourth and fifth finger, you will end up pulling only the index and the middle finger, like an OK sign almost, huh? Except that when you do OK, except that the middle finger is also flexed. That sign that you end up making, and you should do it, should try it, huh? Make the index finger and the middle finger touch the thumb, okay, while the fourth and fifth finger is still standing up. That's your um, claw hand sign, like a claw hand sign, huh, in the clinics. So a claw hand sign means that your fourth and fifth finger cannot pull down. And this is because you have ulnar nerve paralysis. Okay, huh? Ulnar nerve paralysis. All right. So the next nerve is your median nerve, huh? Median nerve. The median nerve supplies the middle finger, right, and the index finger area as well. So when this is a healthy median nerve, it should be able to bring down the middle finger. And when you bring down the middle finger, it actually almost brings the whole troop down, the whole group down almost. So when you make a fist, or when you oppose the thumb all together to meet all of the four fingers, you're able to flex the fingers. Now, the median nerve is responsible for the flexors digitorum, which flexes this middle finger and all the, especially the index also. It almost flexes the whole set of fingers. If you have median nerve paralysis, the flexors are not strong or weak, and therefore, and the flexors are in the front of your forearm. When you're in anatomical position, the front of your forearm is where the flexors are. Flexors, flexing the fingers, if you would. Now, the flexors are weak, so what would happen is the healthy extensors at the back of your forearm will dominate. And when they dominate, they will pull back the hand as if they were the hands of an ape, uh, ape-like posture of the hand. So we call that the ape hand sign. A median nerve paralysis results in an ape hand sign. Okay, ape hand sign. In median nerve, you will also notice that the thumb, yeah, you see your thumb, there's a chunky mass underneath the thumb, right underneath the thumb. That chunky part of your thumb, the base of the thumb, is called the thenar muscle. Thenar, Thenar, thenar muscles. These thenar muscles are also in ways supplied by the median nerve. So when you have a median nerve paralysis, you will see these thenar muscles flat. In fact, you'll see the skin almost like wrinkly because there's no muscle stimulation there. The muscles are atrophic, right? They're not active. That's another sign of median nerve paralysis. Median nerve paralysis can also result in conditions when the hand is flexed or hyperextended in for a long time. Like for example, data entry on the keyboard making you flex for a long time. It can result in CTS, carpal tunnel syndrome. Carpal tunnel syndrome. So here, those are the deficits of the median nerve. Median nerve. Okay, huh? So in essence, remember Dr. Kuma. Dr. Kuma, DR for doctor, and then Kuma, CUMA. It stands for DR is deficit of the radial nerve or radial nerve paralysis. R results in a wrist drop, huh? Okay. While Kuma, C stands for claw hand because of a deficit in the ulnar nerve. and therefore you display a claw hand sign. MA is because of the median nerve paralysis displaying an ape hand sign. Ape hand sign, huh? Also on the cutaneous side, if you have a numbness close to the shoulder, that area is also partly supplied by the axillary nerve. So remember arm, ARM, area just above, just around the shoulder on the lateral side, numbness there, maybe a deficit on the axillary nerve, area about an inch above the elbow, area there supplied by the radial nerve, and an inch below the elbow, area there supplied by the musculocutaneous nerve. So the movements or the signs that you see, plus the numbness that the patient displays, makes the diagnosis more prominent. Okay, huh? All right. These are nerves that are produced from your brachial plexus. By the way, class, be good at this. For example, the question was, or your patient says, they said I have a problem with my radial nerve. Number one, know the deficit, right? Inability to lift the arm because the deltoid is affected, and also what plexus does it belong in? Is it the cervical plexus, the brachial plexus, lumbar plexus? Be able to know where they belong. Okay, great. You can also use that if you're in the ER. If that part of the body was traumatized, then you would almost expect you could check, make the patient. Can you tell the patient? Can you flex your fingers? Can you flex the index? Can you flex the median finger? See, that's where you apply it. And therefore, you'll have an idea if the patient's having a claw hand sign, an ape sign, a wrist drop. Help you uh, pinpoint the nerve that is being jeopardized or in a deficit. See how all this has have applications in the clinics. All right, so that's your brachial plexus. Then you will have, here's a picture of the brachial plexus in the human remains. Huh? See, look at that. Those are like telephone lines almost. But this makes up the brachial plexus, going down all the way to the shoulders and to the upper arm. There's another picture of it. And from here, you'll see the musculocutaneous nerve, the axillary nerve, right? You'll see the radial nerve producing the deltoid uh, inability to abduct, right? And extensor muscles of the upper arm. Then you also have the median nerve and the ulnar nerve, see? There's also the long thoracic. These are all part of the brachial plexus. Let's go down to the next level, the lumbar plexus. Huh? And from here, you'll see your examples are your obturator nerve, you got your femoral nerve, huh? To name a few. This all supplies the muscles in the area of the thigh. It will further go down, and that will be part of the sacrococcygeal plexus. The muscles around here depend on this lumbar plexus. Then you have, here's an example of the lumbar plexus, huh? Giving you pictures of how they come into the lower extremities. The sacral and coccygeal plexus combine to make from L4 to coccygeal 1, combine to produce nerves like the superior gluteal nerve, inferior gluteal nerve, the sciatic nerve, the posterior cutaneous pudendal nerves. Huh? All these nerves play important roles in stimulating muscles of the buttocks, of the thigh, and also the lower extremities. Sciatic nerve, we also always hear that. That's actually a combined or a combination of the common fibular nerve and the tibial nerve. And when it goes down as sciatic, but it will further divide to supply muscles of the leg. Huh? It will become the common fibular nerve it will become also the tibial nerve. Tibial nerve, if you remember in ANP1, stimulates the muscles of the uh, anterior, uh, anterior muscles of the lower leg. This is responsible for flexing, dorsiflexing your ankle. When you're walking on a carpet, your ankle flexes in order to make the foot glide across the floor to make the next step. See, you don't notice it, but when you bring back the leg to make the next step, you actually dorsiflex your foot so it doesn't scrape the floor. But if you have a problem with your tibial nerve, your anterior muscles here will not be able to work and therefore will not dorsiflex your ankle. And you'll end up scraping the carpet, dragging your foot. Okay, that's another sign that your tibial nerve is in deficit. Here's a picture of the sacrococcygeal plexus also coming from the spinal cord and entering into the area of the muscles. Just to name a few of the injuries, radial nerve will give you, it can be due to crutch that is wrongly adjusted and result in crutch paralysis and wrist drop. It can also result in inability to extend your fingers and extend your hand. That's why you have a wrist drop. Sciatic area will give you sciatica, pain from the gluteal area, um, sometimes burning and sensation going up to the spinal area. Now, these nerves, right, will find their way, their branches will find their way to reach the skin area, level. And when they do, they can also, just like I mentioned on the radius, the axillary, and the musculocutaneous, they can supply the skin close to them. And we call this dermatomes, cutaneous innervation and dermatomes. In fact, you will have the whole body made up into like a map where the dermatomes are shown to supply them. Sometimes they overlap, these dermatomes, because they're really close to each other. So here's your dermatome map. And by the way, imagine, in order to understand how the map was laid out, imagine this patient with his arm extended, arm extended in both hands. It makes like a cross. And also imagine him, his legs are also extended to the side, almost like a frog that's put on the dissecting table. Okay, so if I say that because if you look at it from a spinal point of view, if the hands are up on the sides, lateral, and the legs are also, then when the spinal nerves line out, okay, to supply the area beside them, that is why you will have, for example, C6 reaching the thumb level. So you would imagine, hey, well, the C6 level is over here. How did it stimulate the thumb at the level here, right? So that's why you got to imagine this hand was put up on the sides, and that's where the nerve alignment is. That's the level of the nerve that's supplying C6. So it goes all the way to the tip of the thumb, right? That's how the nerves are lined up, That's how the nerves are lined up. That's why you'll see L4 at the top of the knees. See, it's supposed to be in this level when it was laid out, meaning that's how the spinal nerves are distributed. So you see, just above the maxillary, okay, just above the I'm sorry, the mandible would be C2, meaning the dermatome over there supplied by C2. Now below the mandible you have C3 and then C4. Sometimes a good way to remember it is make it animated. Like I would remember C2 like two fingers right above the chin or right above the mandible. That's the area supplied by C2. I would remember C3 area like a high turtleneck shirt. See, high turtleneck shirt. That's up to how much is innervated by C3. A C4 may be a low turtleneck shirt. See, C5 goes down. It's like the one of the dress that ladies wear that's off the shoulder, right? And if you make a thumbs up sign, that's C6. Now remember, the index finger and the middle finger are part already of C7. C7. And therefore, C8 takes care of the ring finger and the pinky. So if you hold it up to your sides, you will have C6, C7, C8. Better hold it up with the middle finger and the index finger together, while the ring finger and the pinky together. You make like a V. Hey, you make a V, right? And that reminds you of C6, C7, both the index and middle finger, and C8, the ring finger and the pinky. That makes the Vulcan sign. Remember Star Trek? That makes a Vulcan sign, which means be well. Right. Be well. In anatomy, in my ground class, we use that to play around with it. When they learn this area, this part of the anatomy, they we remember this by making a V sign to each other. Because the V sign, the well sign, right, of the Vulcans, reminds you of C6, the thumb, C7, index and your middle finger, and C8, your ring finger and your pinky, right? So dermatomes are well marked and remember there. At the same time, this also shows you that the uh, ring finger and the pinky is supplied by the ulnar nerve, while the median nerve supplies the middle finger and the index finger. Same Vulcan sign. Is that interesting? So in campus, when you see my alumni of A&P 1 and 2, we would pound our chest with a V sign like that, and then make a sign to each other. No, it's just our sort of mark that you've learned this level of anatomy already. Okay, so make sure you to flash to make me that sign, when we see each other on campus. There you go. Now, other landmarks here are at the level of the nipple area, you have T4 or a T5. Sometimes it's considered a T4. Okay, and then at the level of the umbilicus, or we call it the belly button, is T10. T10 belly button. T10 belly button. See? If you know those two landmarks, you could almost approximate T5, 6, 7, 8, 9, all the way to T10. See? Then you will have L1, L2, L3, L4. L4 is that like down on all fours, right? I always tell my class, what is L1? One of my female students, it says it looks like a, what is that? What is that? I think it's an exercise underwear or something. Uh, so that's like uh, at the level of an underwear, L1. L2 may be a regular underwear, and L3 is maybe your grandpa's underwear or something, all the way there. See? All right. S2, S3 are the genital area, a doctor once said S2, S3, S4 keeps the jewels off the floor. See? Ah, kind of greeny, but like I said, in anatomy, you got to make some mnemonics. You got to make some animation. You got to own it. So you'll never forget it. So you're not even memorizing. You're just having fun. And you're just making your right brain come in. See? So with that, whenever you have a deficit of L4, you will have numbness over the knees, and over the lateral side of your thigh. All the way to S1, all the way to L5 down there, So remember the dermatomes, we have a special equipment that we run, okay, which is like it has uh, not really pins, but it has uh, prominent parts to it. So when you run it across a certain body part, the patient will raise his hand when he feels numb on that area, and you can determine what level is affected. Okay, this is the dermatome map. Let's go to the final topic here, reflexes. Very interesting and important part. Reflexes are quick, involuntary, stereotype actions, meaning it will always do that, of glands or muscles when stimulated. Reflexes require stimulation. They will not happen without any stimulus. Reflexes are quick and involuntary. Like I said, it's usually the same method it will react at any given time. It's stereotype. In reflexes, it can include glandular secretion or contraction of muscles. Some reflexes involve somatic nervous system and skeletal muscle. For a reflex to happen, you need somatic receptors, afferent nerve fibers carrying the information, integrating center, right? And then the efferent or motor impulse and the receivers of that impulse. Okay, So you need all that to complete a reflex. For example, you have the popular or the classic knee reflex, Let's first see what's in the anatomy of this in order to understand the reflex. Well, in reality, you have the biggest muscle here, right? Your quadriceps femoris, right? The quadriceps femoris is handled by a tendon, like major muscles in the body, by a tendon. But a tendon crosses on top of the patella to insert at the tibial bone, Right. So that's a long uh, display of the muscle plus a tendon that displays that attaches at the tibial bone. Okay, so what happens is when you strike the lower part of this knee with a neurological hammer, you actually tap or press on the tendon of this big muscle, quadriceps femoris. When you tap that, you pull this muscle really instantaneously in a quick second. You pull that muscle because you pulled the tapping sort of pulls the tendon because it's being indented, right? So that momentary sensation of being pulled will be sent to the spinal level, which will make you, right? This is a spinal reflex. It will send signals to your muscles to contract because it was sort of pulled. So in defense, it will contract back to maintain its position. And that sudden pulling back results in this lower limb kicking up or kicking in front. So a tap here at the area where the tendon is quickly pulls the muscle, wherein the muscle ends up pulling itself back, contracting as a defense mechanism almost. And therefore, by contracting, it will pull on the tendon which is attached to the tibia, and this leg will shoot up, like extend real quick, right? That's your knee reflex. And by the way, we also need to know, if this is the quadriceps femoris, you need to know that the nerve responsible for that would be the femoral nerve, femoral nerve. Then you have your, give me a second here. Then you have your femoral nerve. A muscle spindle, which is also a very important reflex mechanism. So for the muscle spindle, there are stretch receptors in the skeletal muscle. There's also proprioceptors that sense the body position. These muscle spindles inform the brain of the muscle length and body movement. and enables the brain to send motor commands to the muscle when a reflex is initiated. Huh? So in every, oh, what's this? This is the femur, right? Huh? And this is the trochanter, greater trochanter, and this is the surgical neck of the femur. Huh? This is your quadriceps femoris. Now, inside this muscle, let's zoom in. You will see that you have your spindle in there, huh? Right. And therefore, it will be sensitive to any quick contractions. Right, huh? As you do that, once this muscle is instantaneously stimulated, then the spindle will send signals to the brain, huh? A spindle has 7 to 8 interfusal muscle fibers. The nerve fibers are a gamma type motor neuron, right, ending in that fiber. And then what happens is when it is triggered, it will send signals to the spine and to the brain that it has been stimulated. Okay. Standing up upright on a boat or even a moving bus, right, is a manifestation that the spindles are in action. Any slight tilt to the left or right, the contralateral muscle will contract in order to keep you up straight. Right? And it's continuous interaction. There's a stretch myotatic reflex is when a muscle is stretched and it fights back, just like what happened with the knee reflex. It's also used in stabilizing equilibrium and posture. Stretch reflex is mediated primarily by the brain, but the spinal component can be uh, involved also. It actually makes it quicker, such as the knee jerk patellar reflex, and then we also have some somatic reflexes. The biceps, right in front of your arm, upper arm, has its tendon inserted into the radius. Huh? So what happens there is when you tap that tendon, it will make the biceps contract. And by contracting, you end up flexing the elbow. See, flexing the elbow. We call it your biceps reflex. Your triceps also can be tested by hanging it on the lateral with someone holding your arm, and you tap just below the elbow, or actually just above the elbow, about an inch or half an inch from the elbow. When you tap there, you actually tap the triceps tendon, and therefore the radial nerve will activate the triceps. Once you tap the tendon, that tendon experiences a contraction or a pull on the muscle of the triceps, and it will quickly contract, just like what happened here, right? That myotatic reflex, when a muscle is stretched because of its tendon being tapped or depressed, the muscle quickly contracts like a defense mode to bring back almost like a homeostatic reflex to bring it back to normal status. So that fighting back actually ends up in a contraction. So the triceps will contract, making the forearm kick outwards, huh? And that's called your triceps reflex. There's another reflex when you kneel on a chair with your ankle hanging over the edge of the chair, and someone uses a neurological hammer to tap your tendon near your calcaneus or your heel area. That tendon you can feel there is the strongest tendon in the body. Huh? That's your Achilles tendon. So when you tap that, it momentarily stretches, right, the muscles of the calf, gastrocnemius muscle, even the soleus muscle. And so when it's stretched, it will right away contract, producing an ankle jerk, right? I would remember that as testing your tibial nerve responsible for these muscles of the calf, okay? And we just explained this, huh? Patellar tendon reflex. There's another reflex called the flexor withdrawal. You pull back reflex. Flexor withdrawal reflex. Quick contraction of flexor muscles resulting in withdrawal of a limb from an injured stimulation. A trigger contraction of flexors and relaxation of the extensors occur. There is a poly, meaning many, polysynaptic reflex, which signals travel over the synapses. So this will be very efficient, especially in when you step on let's say a nail, right? By doing that, you quickly take off your leg or your foot from that nail. That's your flexor withdrawal reflex. That can also be tied up with the cross extensor reflex. It's a contraction of the extensor muscles in the limb opposite of the one that is withdrawn. For example, in that same case scenario, when you step on that sharp object, it will make you pull up uh, and activate your um, flexor withdrawal, because it's flexing at the knee. And then because of that, you will tend to lean to the other side first momentarily in order to lift this leg, right? And that's part of your cross extensor reflex. Cross extensor reflex. Whereas where this flexion, an ipsilateral reflex, ends up being held by a cross extension reflex to make you stand on the other limb, so you can pull the foot from the maybe a nail or some object, right? That quick shift of weight is partly your cross extension reflex. Intersegmental reflex. The input and output occur at the same level of the spinal cord. Pain in the foot causes contraction of the abdominal muscle, and that can happen. This is a picture of the flexor and cross extensor reflex when a patient accidentally steps on something sharp, and you maybe don't even see it, like it's at the bottom of some level of water. That would elicit severe pain and stimulus, and will make you flex your knee, as in a flexor withdrawal situation. And then simultaneously, while you're doing that, you will fall back on the more stable leg, uh, because it will be activated by your cross extension reflex, making your safe legs carry the weight of your muscles so you can lift the injured leg. So both the flexor and cross extension reflex are seen here. Tendon reflex are when tendon organs which have proprioceptors are stimulated, right? Therefore, what will happen is you'll end up having a reflex on those situations. There's a tendon reflex which responds to excessive tension on the tendon, end up inhibiting muscles from contracting too strong, and also helps to clear the muscle from its previous position. By the way, this is the muscle, this is the tendon. We always say the tendon is a strong part of the organ itself, because if the muscles are strong, imagine the tendon. If they're not as strong, this would be a useless organ or muscle, no matter how big it is. Spinal cord happens in the US many times, many cases, depending on what condition happened. Um, Most of them happen in moving accidents like automobile or motorcycle accidents. Spinal cord can also be transected, and when it's transected, it can cut off a lot of motor and sensory tracts. If it's above C4, level of C4, then it can cut off the phrenic nerve and therefore be a threat to respiratory conditions. Paralysis side, if the both limbs, lower limbs, are paralyzed, we call it paraplegia. If all limbs, upper and lower extremities, are paralyzed, we call it quadriplegia. And It can also be that only the left or right side is affected. We call it hemiplegia. Okay. Paresis is when partial paralysis or weakness of the limbs happen. Not not complete, huh? All right, there you go. All right, that ends this chapter, chapter 13, which is a very interesting chapter, as you have seen. Very applicable, especially in our daily cases, huh? Let's throw some quick questions here. How about that? All right. First question is, tell me what plexus this nerve belongs in. And you can say to yourself, A, cervical plexus, B, brachial plexus, C, lumbar plexus, and D, sacrococcygeal. So if I say phrenic nerve, the answer is, aha, you will answer cervical plexus. If I say sciatic nerve, the answer is sacrococcygeal. Again, A, cervical, B, brachial plexus, C, lumbar plexus, D, sacrococcygeal. So for phrenic nerve, it should be A. And for sciatic nerve, it should be D as in delta. Okay, how about musculocutaneous nerve? Musculocutaneous nerve, that would be B as in brachial plexus. Okay, how about radial nerve? Radial nerve would be, yes, it would be your brachial plexus. Okay, Wrist drop is what nerve? Wrist drop is by ulnar or radial, be radial nerve. Ape hand sign, median nerve or ulnar nerve. Ape hand sign is median nerve. There you go. Inability to extend the elbow, which means your triceps is affected, is a deficit of what nerve? Radial or ulnar? Radial nerve. Inability to extend the fingers also by the radial nerve. Okay? Inability to extend, or rather, to abduct the shoulders, which means you have a deltoid problem, is by what nerve? Musculocutaneous or axillary? Or axillary? Yes, it's axillary nerve, Um, inability to contract the diaphragm is a problem of the brachial or cervical plexus. Cervical, Long thoracic nerve, is that cervical or brachial plexus? Brachial plexus, Right. Okay. Uh, sciatic nerve. Did we ask that already? Yeah, that would be your sacrococcygeal plexus, Inability to lift your foot is affected by is a problem with the nerve coming from the brachial or the sacrococcygeal. It will be from the sacrococcygeal. Okay. All right. Let's talk about the meninges. What is the most superficial part of the meninges? Pia, arachnoid, or dura mater? It is dura mater, which is the most visceral or internal part of the meninges. It is pia, arachnoid, or dura. It is pia mater. Okay. All right. Let's go to ascending and descending tracts. You tell me if it's ascending or descending. I'll say corticospinal tract. It is descending. Spinothalamic. Okay, it's an ascending tract. How about your reticulospinal? A descending track. How about sensory? Is it ascending or descending? It is ascending tracks, huh? Okay, good. Which one has lower and upper motor neurons? Ascending or descending? It is descending tracks, huh? Lower and upper neurons. First order, second order, third or fourth order are part of your ascending tracks. Okay, huh? Which one is responsible for sensation below the level of T6? Is it cuneate or gracile fasciculus? It is gracile fasciculus. See? All right. Um, spinal tracts. Okay. How about what do you call spinal nerve tracts that go to the opposite side? Is it ipsi or contralateral? Okay, contralateral. Let's go dermatomes. What is the level at the area of the uh, pinky? What dermatome is responsible for the area of the pinky? Is it C6, C7, C8? It is C8. C8. What what is responsible for the level of the thumb? It is C6. What is responsible at the level of the knee? L2, L3, L4, L4. Okay, huh? There you go, the dermatomes. Um, what is the, in reflexes, for the knee reflex, right? We know it's the uh, flexor reflex, but what nerve is being tested in the knee reflex? Okay, tapping in the knee would stretch your quadriceps femoris, and you're testing the femoral or sciatic nerve. It is femoral. Okay, tapping the radius, I'm sorry, tapping the biceps is actually testing the median nerve or musculocutaneous nerve. All right, tapping on the biceps, testing it, actually is a test of the musculocutaneous nerve. Tapping the triceps, is it stimulating the radius or the ulnar nerve? Yes, it would be stimulating the radial nerve. It's testing the radial nerve. All right, good. There you go, huh? So make sure to remember this, both for the test and also for the clinics. Okay, we'll stop here, and from here we'll go to chapter 15, which will be recorded later on, and therefore you will have your all chapters involved, huh? 12, 13, 14, and 15, huh? Hopefully by this time you have done your discussion, first and second responses. See, if you follow the schedule, you're done. You got nothing more to worry about on that side. And you would have read the chapters, you would have listened to the lectures, you would have gone to connect, look at the cadaver or human remains, and have a solid idea of where we are, and would have gone around the connect items there to some of them also have questions, right? And so therefore you're ready for the week one lab quiz. Week one lab quiz, you go in and there will be about 12 or 14 sets which you can answer. The choices are also there and hopefully make a good grade out of that, huh? And then you will be ready for the practice test for the week one exam. Like I said, you can take it for 3 times even, not only once, not twice, but 3 times, right? You'll be familiar with the type of questions that can be asked to in the week one exam. Make sure you use it if you can to the third time, be better trained and informed, and then go for the week one exam. Okay, week one exam. In between all these, you're processing or doing your assignments, which adds up to the extra credit or the makeup points. Also, don't forget the weekly summaries, which is just a short few paragraphs about a video or an item that's indicated there. Will also add up to the uh, makeup points or extra credit. I would do them. I would not miss on any opportunity. All right. Let's stay there, and then we'll go from there when we apply this in our questions and in our clinics. Okay, good. Thank you for staying and listening to this. Make sure you make notes, make abbreviations, write down new words that you have learned, and make mnemonics. Make your own if you can. Add to the idea, so you can have a lot more mnemonics. Put this in your mnemonics bag or your bag of no of miscellaneous. All right, thank you so much, and we'll get with you soon. Okay, bye bye.